some practical tips for dealing with colon cancer. Okay, I can give you the whole long spiel about all the different, scientific things and whatever, but we're going to hit a couple of high points. We're going to talk about epidemiology. We're going to talk basic science. We're going to talk clinical decision making. We're going to talk who needs surgery, who doesn't need surgery, who needs chemotherapy, who doesn't need chemotherapy, and what does chemo look like. And hopefully we'll get through this fairly quickly, so that way you're not, you have some free time before whatever your afternoon duties are. Okay, so let's see here. Let me get my drawing thing, and let me make it big, and we're going to use U of L red here. Okay, so the first thing is we're going to talk about epidemiology. So colon cancer is number 2. It is the number 2 overall cause of cancer in America, and it is actually, interestingly enough, it is the number 1 cause of cancer in America for people that are non-smokers. Okay, so some people may tell you that colon cancer is only number 2 because lung cancer is really awesome. No, they're wrong. Colon cancer is awesome. We're number 1, right? So it is the overall number 1 cause of cancer. Now let's see if I can figure out a way to aha! Quit, sweet, I cleared it real fast. See, this is going to be awesome. Okay. So, the thing to know is that the overall incidence of colon and rectal cancer every year is somewhere between 125 to 150,000 or so people that develop colon and rectal cancer. And the estimate right now is that in the country there's about 1 million or so people that are, 1 million people that are living with colon and rectal cancer right now. Okay, so the thing to know about that is that's all stages, so stage 1 through 4, right? So you can expect in a state like Kentucky that we're going to have a ton of colon and rectal cancer. So who can tell me what some of the risk factors for colon and rectal cancer are? Just low fiber diet. Okay, good. So I don't know what am I going to do here. So let's do okay. Then we'll do this, and we'll okay, and then we'll make a kind of a smaller, like that, and this and then we'll have this will be the cheese on the hamburger here. Kind of 2 all beef patties, special sauce, all that stuff. So hamburgers, like the all-American diet, right? So low fiber diet is a key component, right? So let's see, low fiber. Okay, what else? First degree relatives, right? So chromosomes, yay. Okay, any idea what particular chromosomes are associated with colon and rectal cancer? Mutations of what chromosomes, or specifically what genes are associated? What? FAP? So that's the disease. What's the gene that's mutated in FAP? APC. Okay, good. All right. What else? What's that? Red proto-oncogene. Okay, so yes, there is one specific version of colon and rectal cancer that is red is much less associated with inherited colorectal cancer than some other things. What goes with FAP? Okay, what's the real name for HNPCC? No, the real name for it. HNPCC. The HNPCC term is old. We don't use HNPCC anymore. It's really called what? Lynch, okay, so it's called Lynch syndrome. That's usually a mutation in what? What? On your path report for colon cancer, you always get back to whether they have what? Okay, so I'm going to draw, this is a sock, okay? And this is going to be a black sock, all right? And then we're going to do like a green sock here. Okay, what happens when you have a pair of socks that don't match? You have mismatched socks. So if you have a mutation in a mismatch repair gene, you get Lynch, right? So if you have an alteration of things that look like this, if they say things like MSH2 or MLH or anything like that, it looks like something LH or SH, M blank H with a number after it, that's a Lynch mutation thing, okay? All right. What other forms of inherited colorectal cancer are there? Anybody know? Anyway, Bueller? No? Okay. So you can also get like weirdomas, like you can get things like von Recklinghausen syndrome, or you can get Banyan-Riley-Ruvalcaba syndrome, or you can get neurofibromatosis, or you can get, anyway, the point of those is that those people are all young and they do universally poorly, okay? So you don't have to worry about most of those because hopefully they'll never get to you. So let's talk a little bit about FAP for a second because, you know, since we're on the topic. So tell me what you guys know about FAP. What does someone with FAP look like? Lots of polyps. How many polyps? 10, 20, 50, 7,000? Hundreds, right? That's just like Polyp City all up in that dude, right? It's just like Polyp Town, USA, polyps all over the colon, right? So it's just like polyps everywhere. Ooh, wait, I have an even new idea. Okay. All right, cool. Now watch this. So we're going to do, yeah. We're going to get some of this, and we're going to make the thing here like this. Oh, baby, it's a colon. Look at that. All right. Oh, yeah. And an anus. Hell yeah. Okay. So, all right. So, FAP looks like what? FAP is just like Polyp Town, USA. It's just like polyps everywhere, and not a drop to drink, right? And they're like, how old are they when they get polyps everywhere? Like, how old? 20s, yeah. Like, so, like 18 or 20 for FAP, right? And then, how old are they when they get polyps in Lynch? 20 to 40 kind of time frame, right? How old are they when you start screening when you know someone has FAP? Like if you have a patient that has known mutation, APC mutation. Roughly, so teenage, yeah, like tween years, kind of tweenish years, then when I start getting an annual colonoscopy. Some people even recommend 15, 16, 17, but most people start screening in the tweens, which, I mean, you get to learn about, you know, your body in new and fabulous ways when you're a tween, including getting a colonoscopy, apparently. So, what does a colon look like for someone that has Lynch? We'll make Lynch blue. Is it like the same thing, like tons of polyps, few polyps, some polyps, one polyp, no polyps? Some, right? So it's like one here, one here. They may have like 10. They may have like, you know, 50 or something. But it's not just like Polyp City everywhere. Now there is, like if you look at the APC gene, if you go above codon 1300 on that gene, you can get something called attenuated FAP, where they have like polyps like all over this dude. But then when you get down to the rectum, which is where this little line is right here, this straight bit is the rectum, then down there's like no polyps. And so you don't have to do a total colectomy on them. You can just like cut it off right there and give them an ileorectal anastomosis. And they can have fun going to the bathroom through the behind normally, which is great. So that's FAP, and we talked a little bit about, so on patients that have a codon 1300 or greater, the other thing that they can get is something called desmoid disease. You guys know what desmoid disease is? You ever heard of that? So desmoids are basically where, it's basically, think of it like a buildup of mesenchymal soft tissue in places it's not supposed to be. So you'll have like the mesentery of the bowel like this, and there'll just be like a big blob of mesenchymal tissue like for no reason. And often left unabated, it will grow and it will obstruct. And one of the most common causes of death of people that have this particular genetic mutation is that these things are recalcitrant to surgery. Like if you cut them, they get worse. They just like spread and get all pissed off and block off the blood flow and everything sucks. Okay, so that's enough about that. So, all right, most of this stuff you're not going to remember, and I endorse that because it's after lunch and, you know, you've been drinking and whatever. So, there are going to be a handful of things I ask you to remember from the lecture, okay? So, number one thing that you must remember is any patient with cancer, any cancer of any kind, I don't care if it's bone cancer or brain cancer or butt cancer or any other B cancer, no, all cancers, okay? Any cancer has 3 parts, and all you have to remember is these 3 things, and you can take care of anybody with cancer. I promise. You ready? It's easy. Cancer's easy, all right? Name. Yay, I love this. This is so much fun. Stage. Whoa. And treat, all right? Name, stage, treat. Name, stage, treat, name, stage, treat, name, stage, treat. So it's literally every cancer you ever see for the rest of your life. All you have to do to remember is name, stage, treat. What does name mean? Someone tell me. What's name mean? What type of cancer is it, right? And how are you going to figure that out? With a biopsy. Outstanding choice. Okay. So name really is just the short way of saying get a piece of that thing, right? You guys ever heard that stupid old rhyme? Like, tissue is the issue if cancer might be the answer, right? So you have to get a biopsy of the stuff and look at it under the microscope, right? Stage. How do you stage a cancer, right? Almost every solid cancer is staged the same way, right? Like invasion, local tissue, nodal involvement, or metastases, right? Liquid cancers like that leukemia stuff, that's staged by smarter people than me, whatever. But like the solid stuff, right, is almost always identified by whether or not it's locally invasive, whether or not there has lymph node involvement, and then whether or not there's metastatic disease, right? And then treatment. Treatment usually consists of one of what three things? Outstanding. See, you just treated cancer. Surgery, radiation, chemo. All you have to do is just pick the right one, right? It's easy. Now I'm going to tell you how to pick the right one. All right? It's real easy. So we're going to take a picture here, and we're going to say this is the wall of, wait, no, this should be brown because it's colon, right? Yep. Yo, dog, I'll put some brown in your colon so that you can have colon while you colon. So the lining of the colon has many layers, just like an ogre or an onion, right? So in my father's colon, there are many layers. No. So seriously, do you guys know all the layers of the bowel, of any piece of bowel, right? Yes, no? You guys remember your histology? Go! Say it. Do, go, yeah. Uh-huh. Uh-huh. Yeah, keep going. Serosa, subserosa, muscularis. Right. Hey, see, you guys know this stuff. So you think you don't know this stuff. You guys are like smart doctor people and stuff. So you guys need to trust yourselves. Muscularis. See, my handwriting is getting better as I go. And then, peritoneum, right? This is like the weirdest thing trying to write with this mouse. Okay. Peritoneum. Okay. And see, this is doctor handwriting, so you guys all recognize this and can read it immediately right off because it's all crappy physician handwriting. Okay. So our staging criteria for colorectal cancer is going to inform our treatment because based on how thick the tumor is, it's going to tell us what exactly we need to do. Is it just to be simple like, cut it out and give chemo, or give chemo first, or put a stent up there, or, give them a fishing pole, or what are we going to do? So, what is different about these two things as opposed to these things is where we're going to stage them. So if we have a colon cancer that is only kind of slightly invasive, either into the mucosa or the submucosa, then that is stage, hey, look at that. Real easy. Okay? And if it's invading even deeper into the wall of the colon, but not all the way through it, it's going to be a, right. And if it's all the way through the wall of the colon, then it's going to be what? No, bad too. This is the tricky part. So, but you're going to remember this is stage 2B because it's bad. Okay? This is the bad stage. This is, all right? So now if it gets all the way out here, that's in the lymph nodes. Okay? And that's what? Stage what? 3. Okay? All right? And if it's like all the way, and all the way over here in the shoes, right? It's a crappy shoe. I'm not good at drawing shoes. I'm like, shoelace, maybe shoelace or something coming up like that. Oh, Nike swoosh. Nike swoosh does it, right? Okay. So this is a shoe. For you watching at home, this is a shoe. Okay. All right. So if it's in their shoes, right, then that's stage 4, right? Okay. Good. So it's real easy to remember how you treat colon cancer based on my awesome drawing here. So if they have stage 1, 2A, or 2B disease, then these people go for surgery. This is a kind of crappy scalpel here. Or something else. Maybe a drumstick. I don't know. All right, let's do that. All right, drumstick. Yum. Okay. And so So those people end up getting surgery, right? And then the node people that we know are node positive, do they get surgery straight off? Yeah, typically, right? So they get surgery, but then they're going to get surgery followed by chemo, right? So everybody on the right of this line is necessarily going to get chemo. Everybody on the left of this line is not necessarily going to get chemo, okay? So the next thing that you need to remember is Farmer's dumb mnemonic for remembering who gets chemotherapy for colorectal cancer, okay? So the easy way to remember who gets chemotherapy for colorectal cancer is in the nodes. That's a lymph node. That's a lymph node. It's got junk in it. All right, lymph nodes in the nodes. I'm going to draw my. It's my shoe again, right? In the shoes. God, wow, it's horrible. In the shoes, and then the bad actor 2s. So 2B disease, right? If it's like perforated through the wall of the colon, they probably need chemotherapy. So in the nodes, in the shoes, and the bad actor 2s, those are the chemotherapy like qualifying colorectal cancer patients. Okay, so let's get back to name, stage, treat. So how are we going to stage people? What are we going to do that? How are we going to stage them? So this is kind of a tricky question, but bear with me here. So how are we going to do this? Okay, so that's a very good viable option, right? So the ultimate biopsy is just to do a surgery and have all the results of the biopsy, pathology and surgery, right? But what if I'm seeing a patient tomorrow in my office? Oh God, it's tomorrow. Seeing a patient tomorrow in my office and they show up and they have a colon cancer seen on screening colonoscopy, and I'm seeing them and I say, oh boy, I sure would like to know if this patient has metastatic disease before I take them to the operating room, because it's going to change my management. Because if they have stage 4 disease, they're going to get chemo, right? If they don't have stage 4 disease, then they're going to get surgery. So how do I figure that out before I put a laparoscope in there? What? Say PET? Okay, so that's like down here. Although it is a good answer. But PET is not the workhorse for colon surgery. That's like number 3 or 4 lower down the list. What's the first thing? CAT scan. What kind of CAT scan? And? Chest, abdomen, pelvis, right? Torso scan, essentially. Right? With what? Okay, what kind of contrast? But focused on the... Yeah, see? I'll put a little crappy gallbladder over here. Alright, cool. That is not at all a liver or a gallbladder, but okay. So CT, chest, abdomen, pelvis, liver protocol if possible, because you want to make sure that the most common location for this to go is into the liver, right? I mean, that's the most common location for colorectal metastases. All right. Say that someone comes in, and actually I have someone coming to see me in the office tomorrow with a mid-rectal cancer. So first off, the rectum is like a totally different bag than the colon, and that's both a colostomy joke and the truth. So the rectum, and this is the outside roll. This is like your toilet down here in the bottom. This is like the everything where the toilet water is, and here's the anal exit. So you can divide the rectum into thirds. Okay, so the upper third of the rectum is at like maybe somewhere between 10 and 15 centimeters from the exit, and then the middle rectum is somewhere between 5 and 10, and then the lower rectum is less than 5. And depending upon how far the tumor is from the toilet, it's going to show up in different nodal places, right? If it's down here, it's going to go to the inguinal nodes. Okay, like you can palpate positive nodal disease like just by putting a hand in your groin and feeling. Okay, and then this stuff up here is going to go to the liver, and then this stuff in here does both. Okay. So one of the ways that you're going to stage these people, in addition to getting your chest, abdomen, pelvis scan, and often will also provide you information locally about the tumor, is to get an MRI of the pelvis. We used to do this with anal ultrasound, and that is as awful as it sounds. for the patient and for me. It's not cool. I mean, it's not true. It's pretty cool. You get these like really cool 3D pictures that you can like take and manipulate around and like stare at the tumor more, and it's like, you feel all fancy and everything, but really no one in colorectal world is doing that anymore. We're all getting pelvic MRIs to stage the rectal part of colorectal cancer, and you can detect lymph nodes up to centimeters in size, maybe sometimes less. And then especially if you're worried about whether or not there is sphincter involvement. So there are these two kind of baseball bat looking things that kind of live down here, one going kind of horizontally and one going kind of vertically, and then there's like a little free space in between them, and this is the internal external anal sphincters, and every once in a while that tumor will invade into the sphincters, and that's bad, because then you're going to have to take all that out. Anyway, so what else are we going to do to stage colon and rectal cancer? So we got imaging. What else? Staging workup. Physical exam, we always do a physical exam. We always take a history. You have any family members with colorectal cancer? Do they have any high-risk malignancy? Do they have a history of endometrial, ovarian, breast, esophagus, pancreas, duodenal cancer? Do they have any GI tract cancers or female tract cancers? Okay. What else? How else are we going to stage them? What else would I normally do in my office if I'm trying to figure out if someone's got liver metastases? Other tests I can get cheaper than... Yeah, CMP is good, right? And if they got elevated liver enzymes or their bilirubin's up, I'm worried about that. All right, what else? Is there a tumor marker for colon cancer? Not 19.9, nope. CEA, right? What's up with CEA? Is that a good or a bad tumor marker? Yes, who said that? Where's check out the big brain on Brad. Who said that?
You get it for recurrence, right? Not for diagnosis.
Right, it's much more useful for recurrence. So if you initially get the thing right off, then and it comes back like 70 bajillion, then you've missed disease somewhere, and you probably would then get a PET scan because your initial round of stuff didn't show it. But normally what you do is you have somebody whose CEA is like, 4 or 5 or something like that. You cut their cancer out, their CEA drops, and then you see them back and you follow their CEAs, and it starts going back up from like 0.5. It's almost like a PSA or something, like CEAs creeping back up, 5, 6, 7, 10, 50, It's time to start looking for the occult metastatic disease somewhere, okay? Anything else? I mean, you probably want, at least a CBC and coags. That's a really bad B. And just so that you can know if they have coagulopathy, if you can operate on them, and all other sort of business. So, name, stage, treat. Okay, so let's get to the treat part of it. How are we going to treat them? So it depends on where in the colon their tumor is. Ooh, okay. Who knows something about the blood supply to my favorite organ? Somebody should. So what is unique about the blood supply? This is anatomy now. We're going all the way back to all the oldies and goldies, right? So what's unique about the blood supply to the colon in terms of think embryologically? Splenic flexure. Okay, good. I'm glad you said that, because the splenic flexure is the watershed area, which means there's like a paucity of blood vessels. Like there's blood vessels going up like this, and some over here, and this guy gets a blood vessel, and you get a blood vessel, and you get a blood vessel. But the splenic flexure doesn't, right? It and the sigmoid colon, the rectosigmoid junction, are two watershed areas, meaning that they typically receive very low blood flow. So if you're looking at ischemic colitis, then you want to look at the rectosigmoid junction or look at the splenic flexure. Okay. So, in reality, the blood flow to the colon is interesting because right about here is the junction between the what and the what? Embryologically. Yeah, midgut and the hindgut. And you can tell that because all this stuff over here is supplied by the IMA, and all this jag over here is supplied by the terminal branches of the SMA, right? The middle right and the middle right and ileocolic arteries. Middle, the right. And you guys remember the old mnemonic MRI? That's how you remember the terminal branches of the SMA. So middle right and ileocolic arteries, dig. So this stuff is if the tumor's over here, then you're going to end up taking out pretty much everything up to there. If the tumor's over here, then you're going to take everything between there and there. If the tumor's here, then you're going to take everything between there and, basically the toilet kind of almost thing. But the point of it is that there's not at any point is there like if a tumor is here, there's not any point where you just do like this to this. Like that as an operation doesn't exist because of the redundant blood supply. A transverse colectomy is like a made up surgery. So if you ever like hear about someone having a transverse colectomy, then you need to counsel your surgeon that they're stupid and send them to me. We'll listen, I promise. Let's see. So what type of treatment? So let's say we do our colectomy and it comes back that our patient has nodal involvement. First of all, how many lymph nodes do we have to have for adequate pathology on colorectal cancer? 12. Who says so? She does. Now, in reality, who says so? So in 1992, the working group of gastroenterology, international working group of the American College of Gastroenterology and International something, important old people said that we had to have 12 nodes, right? And the reason for that is because they think that if we get 12 nodes, that's an adequate sampling to determine whether or not someone has nodal metastatic disease. Some people think that you have to have 20. Some people think that you have to have 30. And some people think that there's a direct correlation that if you get more nodes out, your overall survival goes up. But not really. And so they've actually studied this. And so 12 is more than enough. As long as your tumor is not like super punchy through the wall type of tumor, not like a bad T4 tumor, right? Then 12 nodes is certainly enough. So you got to get 12 nodes. And so let's say that our patient comes back with positive nodal disease. What type of chemotherapy are they going to get? What is FOLFOX? Who said that? Jesus. He studied. You're not supposed to study, dude. Did they tell you that? Yeah, you're not supposed to do that. Make everybody else feel bad. Me, including me. I didn't know that. No, I'm just kidding. Alright, so FOLFOX, 5-FU, oxaliplatin, leucovorin, right? I still don't know where the other I don't know, I'm not sure exactly how they come up with that, but FOLFOX, right? So 5-FU. So how can you give 5-FU? What are the different methods of giving 5-FU? You guys know? You guys know how 5-FU can be given? If there's more than one, I'll break it down. There's two. What are the two main ways we give them? I'm not giving anybody intrathecal 5-FU, okay? I'm not going to give them intraocular 5-FU. I'm not going to put like a port in their eye. All right? So what are the ways that I can give someone 5-FU? Okay? Right? IV or... Yeah, someone burped, right. Oral. I don't know who burped, but that was right. So you can give people oral 5-FU. So you can give them something called capecitabine, or also it goes by the name the trade name is XELODA. You guys ever heard of Xeloda? All right. So Xeloda actually is broken down by the body into the same metabolite as 5-FU, and it works just the same. So the patients that are getting radiation therapy preoperatively for rectal cancer, instead of getting infusional 5-FU, they just take oral capecitabine, and then they get the radiation to sensitize their tumor to radiation. So, all right, and then what about the other stuff? What about this other business, the leucovorin and oxaliplatin? How's that given? Right, it's given IV. So typically, when you look at a calendar way that this breaks down, typically what happens is they go in and get like, on day one, they get this stuff for like the morning, and then they get sent home with a fanny pack of 5-FU, and then they'll disappear for, a number of days and then come back and repeat that process the next week, and then take a week off and then come back. So it's like 2 weeks on, 1 week off, 2 weeks on, 1 week off. And then each one of those 2 weeks on and 1 week off is a cycle of chemotherapy, right? So when people talk about the patient got 3 cycles of FOLFOX, what they're actually saying is that the patient received a weekly infusion of 5-FU that they carried around for 48 hours with the addition of a morning time, Monday morning or whatever time, infusion of leucovorin and oxaliplatin. They did that for 2 weeks and then took a week off. Like that's what... But we can't say all that just like every time. So we shorten that by saying, hey, I got 3 cycles of this thing with an acronym that I just completely made up. Right? All right. Are there any other options out there for chemotherapy for colorectal cancer? There must be, or I wouldn't have asked. What else? What? So cisplatin is not frequently used for colorectal cancer. So the next choice, the second line treatment is FOLFIRI, which is the addition of irinotecan, FOLFIRI. And then you may also, that often replaces the oxaliplatin component, or you can also have FOLFIRINOX, which is all of the original things plus irinotecan. And then you start getting into all the weird, like crazy cool basic science stuff. So you can get into things like Avastin. Have you guys ever heard of Avastin? Okay. Avastin is good for patients with stage 4 tumors that respond to anti-VEGF stuff. And some people get real great responses to them. Not everybody does. The problem with Avastin is if that patient is going to need surgery anytime soon, they will not heal. So you have to think long and hard before starting someone on Avastin and say, yeah, I'm not planning on operating on this patient, or I'm not planning on having my surgeon operate on this patient because if you operate on them, the wound won't heal, their anastomosis won't heal, and they'll just kind of crumble up and just won't work. The other thing is that Avastin is not without complication. Their tumor can perforate if they're on Avastin, and it's actually happened. I mean, we presented someone in a multidisciplinary conference on Monday who had a colon cancer that perforated on Avastin. So Avastin is good for stage 4 disease, but it's not without risk. And then you get into a bunch of the other monoclonal antibody things. Do you guys know what KRAS is? Have you ever heard of KRAS? What's KRAS? What? Right, but what does it do? How is it active? So it's part of the beta-catenin and WNT pathway, and basically what it ultimately it's one of those kind of escape mechanisms that perpetuates the ability of a tumor to have kind of early escape and continue dividing and replicating and whatnot. So KRAS is actually a potential target for monoclonal antibody therapy, and you can give patients monoclonal antibodies that target KRAS if they are what we call KRAS wild type. About roughly 45 or 50% of patients with metastatic disease, which is what you'd use this for, are KRAS wild type, and there are candidates to get anti-KRAS stuff. There's also KRAS mutant, which means that their KRAS has mutated, and if they're a KRAS mutant, then they're not eligible to get this kind of whatever antibody kind of drug here. What else do I want to tell you about? Okay. Okay. Let's say you have a 65-year-old guy who comes in and he's got a right colon cancer and he's got iron deficiency anemia, and the tumor has spread to his liver, and it has taken the lumen of his bowel and almost completely obstructed it, but not quite. Right, but not adjuvant, neoadjuvant. Right. So remember, neoadjuvant is before surgery, adjuvant is after surgery. So you want to give him neoadjuvant chemotherapy, right, especially because he's got stage 4 disease in his liver. But the thing you worry about, sorry, my phone's going crazy. So the thing you have to worry about is this tumor obstructing. Dig? So one of the things you can do is you can stent that bad boy. Whoa! Control Z. You can stent that bad boy open. If you can get a wire across it, you can probably get a stent across it and let them get their neoadjuvant chemotherapy and then come back and take that stent out when you take the tumor out. That's the other thing I was going to talk about. Okay, so there is the classical pathway that you guys may get tested on that is the adenoma-carcinoma sequence. Have you guys ever heard of that? Like, the idea behind screen colonoscopy is you start off with this little thing, and it gets bigger, and then it gets super huge, and then it, like, sinks, like the stalk dies and sinks down, and then it becomes a cancer, right? And then as you progressively lose mutations like, P53 and DCC and APC and all that sort of stuff, as you lose a gene, every time you lose a gene, you move somewhere up this tract along, going from like a little bitty adenoma, a little bitty hyperplastic polyp to an adenoma to a sessile adenoma to a cancer, right? That's the traditional adenoma-carcinoma sequence. And it's related to a series of specific genes that you probably all heard of: APC, DCC, deleted in colon cancer, P53, all this stuff, right? So, by the way, just a cheat code for you going forward: tumor suppressor genes are in all caps, except for P53. Proto-oncogenes are always all lowercase. So if you see a question on a test that's asking you about a proto-oncogene, don't pick a thing that's in all caps, because that's a tumor suppressor gene. If someone's asking you about a tumor suppressor gene, don't answer something that's in all lowercase, right? So that's your cheat code for those confusing things. All right. So this is what we thought all tumors did for like years and years, forever and ever, amen. We're actually coming to find out that roughly only about 60% of all colon and rectal cancers follow this traditional pathway. Roughly about 40% of them follow like a totally different pathway of carcinogenesis. And there are probably about 2 or 3 major proposed pathways out there now. I won't go into the basic science of it because it's just boring for you. But the long and short of it is, now we're finding out that there are these things out there called serrated adenomas. Have you guys heard of this? Yes, no, maybe? Okay. So there are new types of polyps that we're discovering as we do more colonoscopy out there that are called serrated adenomas. They follow a completely different pathway of carcinogenesis. It's related to hypermethylation of promoter genes, all that sort of business. But long and short of it is, you can go, this traditional pathway we thought takes somewhere between 5 to 10 years to create a cancer. The new pathways we have, the serrated adenoma pathway and the Lynch CMP, CAPG island promoter pathway, can develop a tumor in 1 to 2 years. And so the interesting thing about that is that we have a huge surfeit of people in the kind of Kentuckiana area that are young people with colorectal cancer. We got people that are like developing sporadic cancer, not inherited cancer, not new mutant FAP, not new mutant Lynch, not, new mutant whatever thing. They come in with sporadic colorectal cancer, and they're like 32, 35, 40, 45. They have no business having these things, and maybe it's iPhones. I mean, I don't know what it is, but whatever the ultimate cause of this thing is, it's probably not the traditional adenoma-carcinoma sequence that we think of, because it takes forever those things to become a tumor. It's probably these kind of altered methylation pathways that are related to serrated adenomas and Lynch syndrome that ultimately are leading to these things. And this is kind of an area of focus for future research for us here, because we lead the country in underage people with colon and rectal cancer. I mean, we also lead the country per capita in colorectal cancer anyway. But we are of the top 25% in the country in terms of overall per capita cases of colon cancer. We have the number one in terms of disease-free and overall survival. So we're doing something right.